So it's 3, 2, 1. Over to you, Lokesh sir.
Hello, everyone. Myself, Dr. Dronamari Lokesh Sai, Medical Affairs Department, Macleods. So, as we all know, India has a diabetic burden, very huge quantity. And also, one of the 7 persons in the world diabetics are Indians, which is one of the major risk factor for the microvascular as well as macrovascular complications. So, on which more guidelines are more focusing nowadays. So understanding therapy and molecules also very, very important in current scenarios. So for that, we have with us Dr. Aman Sinha, MD, DM cardiologist, intervention cardiologist at Subkanam Heart Hospital, Gaya, Bihar. Sir's special interest includes coronary interventions, congenital heart disease, pediatrics as well as adults. And sir is also a member of API, ICC, CSI. Sir also has been published various articles in peer-reviewed journals. And it's my pleasure to introduce you, sir.
Thank you. Thank you. Can I now share my screen?
Sure,
Yes,
sir.
sir. Yes, sir.
Good evening, everyone. I'll be talking on controlling diabetes and cardiometabolic risk, putting double power into practice. So first, I'll be going through the unmet need of glycemic control in today's scenario, the need for a complementary combination for cardiometabolic care, the place of this complementary combination in today's practice, the real-world experience, and of course, what the future holds for combination of Vilda and Dapagliflozin. So the prevalence around 8.8% population in the world is suffering from diabetes. That is around 425 millions. This is the global scenario. In India alone, the prevalence is 8.8 and 72.9 millions. Of course, we all know that India is the diabetes capital of the world, only just beside China. So India is home to the second largest number of adults living with diabetes worldwide after China. In 2017 alone, India was the largest contributor to the regional mortality with nearly 1 million estimated deaths attributable to diabetes. Diabetes patients experience an up to 50% increase in cardiovascular related deaths, and India is the leading cause of chronic kidney disease, and approximate 1 out of 4 adults with diabetes has kidney disease. So what does 1% increase or decrease in HbA1c means? We all focus upon the treatment goals as per HbA1c, that is whether it reduces HbA1c to more than 1, more than 1.5, to less than 0.5. So what does it mean? So every 1% increase means that is there is 38% initial chances of CVD event, 28% chance of subsequent cardiovascular disease events, 54% chance of initial major adverse CV event, that is straight away to myocardial infarction, or 89% subsequent major adverse CV events. What does 1% decrease in HbA1c hold for the patient? That is 21% decrease in diabetes-related deaths, 14% decrease in myocardial infarctions, 37% decrease in microvascular complications, and 43% amputations or deaths. So what is the most common fear and concern of participants of type 2 diabetes at the time of the diagnosis? Of course, the first and foremost is risk of severe complications. Obviously, if they don't control the diabetes, the risk of complication is always there, whether the patient is young or old. Second is, of course, there are multiple food restrictions and they have to undergo through the same, because the first point is lifestyle modification, and that they have to control their diet strictly. Third is side effects of antidiabetic drugs, and others are risk of high glucose fluctuation, need for regular blood glucose testing and insulin injections. So what is the main unmet need for participants? They don't get proper information and support about food and diet. Of course, a lot of OPD patients are there at every point, and so they cannot interact with doctors. Doctors should always put in time and effort to give more information and to clear all the doubts, whatever they have about their food and diet. Then coming on to, they have a new solution to measure and track blood glucose. An awareness campaign about diabetes should encourage early diagnosis and more information about diabetes causes and consequences. So the need for personalized diabetes management to effectively prevent the development of cardiovascular disease and type 2 diabetes, considerable effort has been made to explore novel preventive approaches, individualized glycemic control, and cardiovascular risk management, together with recently developed glucose lowering agents. We can all see that among all cardiovascular diseases, The top rank is coronary artery disease. Second is heart attack, that is myocardial infarction, stroke, heart failure. So diabetes does not only cause ischemic heart disease, it can directly cause heart attack, it can cause stroke, and it can cause heart failure because of diabetic cardiomyopathy, and obviously it can cause peripheral artery diseases. So according to the latest recommendations, that is according to American Diabetes Association, patients with type 2 diabetes established atherosclerotic cardiovascular disease or multiple risk factors for cardiovascular disease or established kidney disease, irrespective of additional glucose lowering and metformin use, we can always add SGLT2 inhibitors and or we can use glucagon-like polypeptide. Second is SGLT2 inhibitors can be used for patients with type 2 diabetes and established heart failure with reduced ejection fraction. We all know that SGLT2 has brought a revolution in the treatment of heart failure with reduced ejection fraction. We have all the trials for that. Then third is initiated with, if the patient has been initiated with metformin, patients with type 2 diabetes or stable heart failure. We can always initiate with SGLT2 inhibitors or GLP the patients with newly diagnosed diabetes with established atherosclerotic cardiovascular disease or very high risk factors for CVD before metformin use. This has been promoted by European Society of Cardiology. Then if the patient can be initiated directly on metformin, if patients are overweight with diabetes without any complication or any risk factors. We can also again initiate with metformin in patients with diabetes with atherosclerotic cardiovascular disease and initiated with SGLT2 inhibitors with the patient with diabetes and without. So basically all are almost the same. If there are no risk factors, the patient is overweight, we can directly start with metformin. If there are any risk factors like cardiovascular disease risk factors, we have to go with SGLT2 inhibitors or glucagon-like polypeptide 1. So if a patient has diabetes, first and foremost, we have to promote glycemic control. If the patient is having glycemic control, we have to go for weight loss programs or to give those drugs which do not promote weight gain. In fact, after that, we have to go for those drugs which does not cause hypoglycemia. And of course, after that, we have to promote that less risk factors develop, or if risk factors develop, we have to minimize the cardiovascular risk and the chronic kidney disease risk. So we can see that the last 2 points are if atherosclerotic cardiovascular disease predominates or if heart failure or CKD predominates. So the need for a complementary combination for cardiometabolic care came, and sequential addition of SGLT2 inhibitors to DPP4 inhibitors may be considered cost-effective compared with standard treatment using sulfonylurea insulin for patients with type 2 diabetes who have difficulty in maintaining glycated hemoglobin of 7% or less on metformin alone. So initially, what was the protocol that a patient was diagnosed with diabetes? Initially, we always used to put metformin first. But if HbA1c is more than 7, we can directly go for combination therapy so as to decrease the HbA1c to less than 6 or 6.5. So what is the mechanism of action? So why are we talking about the combination therapy of DPP4 and SGLT2? They both have a very complementary mechanism of action. That is, SGLT2 promotes glycosuria. It promotes glucose lowering in the blood. And with that, glycosuria produced by SGLT2 is associated with an increase in the rate of endogenous glucose production, which offsets the glucose lowering effectively by approximately 50%. So if DPP4 is added with SGLT2 inhibitors, what it does is it reduces the endogenous glucose production by decreasing the glucose secretion, and it stimulates insulin secretion. So whatever endogenous glucose production was increased, it is reduced by DPP4. So it's a good combination and both complement each other. Coming on to the mediating pathways, so we can see that glucose-dependent insulin secretion and glucose-dependent decrease in glucagon secretion both are caused by DPP4 inhibitors. And SGLT2, apart from that, increases glucagon secretion, increases glycosuria, both increase beta cell sensitivity or function, and SGLT2, because of its glycosuric action, it decreases the glucose toxicity. Apart from that, DPP4 also has anti-inflammatory effects. Upon the physiological effects, both cause HbA1c reduction, both cause fasting plasma glucose reduction. SGLT2 promotes weight loss as well because of natriuresis, diuresis, and glycosuria. And apart from that, it also causes blood pressure reduction. So what are the CV outcomes? We all know that SGLT2 has superiority over other drugs if production of cardiovascular outcomes is there. So we cannot see that cardiovascular outcomes, hospitalization for heart failure, mortality, renal events, and serum lipids all decrease because of SGLT2, and lipid profile is almost unchanged with both the drugs. Now, the Asian Indian phenotype is characterized by increased visceral adiposity. We all know that we have central adiposity and lower metabolic tolerance and increased cardiorenal risk. The expert opinion serves as clinical guidance for the optimum use of therapeutic combinations of DPP4 inhibition, sodium and SGLT2 inhibition, management of Indian Asian population with type 2 diabetes. The combination of agents with proven benefits may be preferred for patients with higher predisposition to cardiovascular events and kidney disease. So the complementary combination, what is the place in therapy in today's scenario? So coming on to case-based scenarios, first is a patient with 56-year-old patient with 4 years of diabetes, recently divorced, and he works as a contractor. HbA1c is 7.9%, and he is on SGLT2 inhibitors, a DPP4 inhibition, and metformin. He's also taking ARB, and he's on statin. So we can see that the number of pills is reduced because the patient is taking all the 3 drugs, and it reduces the number of pills, reduces the number of dosages, and it is the like anti-hyperglycemic drug with a lower risk of hypoglycemia and weight gain. So coming on to scenario 2, a 39-year-old South Asian woman with neurodirected diabetes. She has a strong family history of type 2 diabetes with gestational diabetes 4 years back when she was pregnant. And her current BMI is 25.3, that is overweight, and fasting glucose is 162, HbA1c at diagnosis is 8.6%. Again, we have to start aggressively so that if the next pregnancy is there is no chances of any gestational birth defects, and a fixed dose combination of SGLT2 inhibitor, DPP4 inhibitor, and metformin is a reasonable opinion. So coming on to appropriate use of SGLT2 DPP4 inhibitors, that is a fixed dose combination based on glycemic controls. So first of all, patient is diagnosed with diabetes, or any patient who is already diabetic patient comes to us. We have to first treat the patient. That is, we have to first treat the mentality of the patient, that is lifestyle modification. We have to ask for diet modification, exercise, and whatever we can do. After that, we have to see whether the patient is a treatment naive or already patient is receiving some treatment. In treatment naive patients, where metformin is contraindicated, intolerant, and HbA1c is more than 8%, or in treatment naive patients who already were put previously on metformin, the combination of metformin in patients with baseline HbA1c is more than 9%, or uncontrolled metformin monotherapy, we can start directly with SGLT2 inhibitor and DPP4 inhibition based on glycemic factors. Now again, the fourth scenario is uncontrolled on metformin and DPP4 or SGLT2 inhibitions. We have to either use DPP4 or SGLT2 if the one is not given. Fifth is if the patient is uncontrolled on metformin and the second line agents except DPP4 SGLT2, we can add this fixed dose combination of DPP4 inhibitors and SGLT2 inhibitors where HbA1c is 8.5% or other glucose lowering medications, and we can replace the HbA1c above 7.5%. If the patient is on insulin, other drugs, we can add on this combination therapy if the patient has been taking insulins despite HbA1c is more than 7.5 or 8%. Again, based on CV risk, including heart failure, SGLT2 inhibitors, it has proven CV and heart failure benefits, and preferred agents in cases where patient has heart failure or risk factors for cardiovascular disease there. DPP4 inhibitors, it's proven cardiovascular heart failure safety, such as Vildagliptin and Vildagliptin, have shown a favorable cardiovascular safety profile, including no increased risk of hospitalization due to heart failure in their cardiovascular outcomes. This combination may be preferred over other conventional therapies in cases of established cardiovascular disease and or risk heart failure. Again, if the patient is having CKD, SGLT2 inhibitors can be used even if eGFR is less than 30, if eGFR is more than 30. I have already used a lot of patients on CKD patients where eGFR is almost 30 and it does not cause any further deterioration in the eGFR. And SGLT2 with positive kidney outcomes and cardiovascular trials should be preferred in kidney diseases. DPP4 also are very safe in kidney diseases. Coming on to promoting weight loss or preventing hypoglycemia, SGLT2 inhibitors promotes weight loss, DPP4 inhibitors are weight neutrals. This combination may be preferred over other conventional therapies to promote weight loss with no increased risk of hypoglycemia and type 2 diabetes management. Coming on to the real world experience. So we can also see that complementary mechanisms of actions of SGLT2 inhibitors and DPP4 inhibitors result in clinically meaningful and sustained reductions in HbA1c. As you can see in the graph that when Dapagliflozin and Saxagliptin was used along with metformin, around 1.4% reduction of HbA1c was there. Again, we can see that DAPA plus Saxa and metformin combination reduced the fasting blood glucose to around 38 milligram deciliters. Now coming on to the primary endpoint, that is glycemic control. So if DPP4 inhibitors are used as an add-on to metformin, there is 0.51% reduction in HbA1c as compared to placebo, that is 0.16. If SGLT2 is used as an add-on therapy to metformin or DPP4, again a 0.82 reduction in HbA1c is seen as compared to placebo, that is 0.1%. So what does Vildagliptin plus Dapagliflozin holds for our future? Clinical effectiveness and safety of Vildagliptin done on more than 19,000 patients with type 2 diabetes, which is the GUARD study. We can see that at week 24, mean HbA1c was reduced significantly from baseline by 1.27%, and significant reductions was reported regardless of patient age, BMI, or baseline HbA1c. So Dapagliflozin has been shown to decrease HbA1c values from 0.15% to 0.7%. Again, Dapagliflozin is effective as an add-on therapy to Vildagliptin, Saxagliptin with or without metformin. And at week 24, Dapagliflozin significantly reduced mean HbA1c level to around 1.5% to 0.7%. Study results suggest that in patients with type 2 diabetes inadequately controlled on gliptin with or without metformin, add-on treatment with Dapagliflozin provides additional clinical benefit and is well tolerated. Coming on to the weight neutrality with the DPP4 inhibitors, Vildagliptin. So DPP4 inhibitors are generally weight neutral, although the modest weight loss has been observed with DPP4 inhibitors Vildagliptin in patients with relatively low baseline glycemia. The weight neutrality of Vildagliptin likely results in part from its intrinsically low risk of hypoglycemia, and Vilda plus metformin provide clinical relevant glycemic and weight control and was well tolerated in a large multi-ethnic type 2 diabetes patient population studied in routine clinical practice. Apart from that, we all know that Dapagliflozin significantly reduces body weight to around 2.2 kg, and we all know that what 2.2 kg weight reduction in diabetes population means. So coming on to Dapagliflozin and cardiovascular outcomes in type 2 diabetes, that is declared CME 58 trial. This was a it had a positive outcome, that is Dapagliflozin SGLT2 inhibitors with the broadest indication to reduce the risk of hospitalization for heart failure, 27%, relative risk reduction in over, that is 0.8%, absolute reduction. First, this declared CME trial came, that is the patient was having diabetes, and in that diabetes population, heart failure was there. So the Dapagliflozin, when it was introduced in the patient with diabetes and heart failure, it reduced the overall cardiac mortality. Now, after the declared CME trial, DAPA-HF trial came. In that population, the patients with or without diabetes having heart failure, if Dapagliflozin was added, it also gave positive impact. Coming on to Dapagliflozin patients with heart failure and reduced ejection fraction, that DAPA-HF trial, which I was talking about, that is among patients with heart failure and reduced ejection fraction, the risk of worsening heart failure or death from cardiovascular causes was lower among those who received Dapagliflozin than those who received placebo, regardless of presence or absence of diabetes. This came after declared CME trial. Coming on to Vildagliptin lowered albuminuria in type 2 diabetes with hypertension independent of glycemic control. So Vildagliptin resulted in substantial reductions in albuminuria in patients with type 2 diabetes and hypertension on top of RAS blockage, that is renin-angiotensin system, after short-term therapy independently on glycemic or hypoglycemic changes. Coming on to Dapagliflozin patients with CKD, that is DAPA-CKD study. Among patients with chronic kidney disease, regardless of the presence or absence of diabetes, the risk of composite or of a sustained decline in the estimated GFR of at least 50%, ESRD, or death from renal or cardiovascular causes was significantly lower with Dapagliflozin than with placebo. Then coming on to the Vildagliptin and Dapagliflozin combination summary. So we all know that the patients should be put on a combination therapy. If HbA1c is more than 8%, the patient is treatment naive, we can directly start the combination therapy, whether or not patient was receiving a metformin or not. So first is Vildagliptin and Dapagliflozin should be given once a day. The frequency of dosing is OD, should be given in the morning because of diuretic effects of Dapagliflozin. The indication is uncontrolled diabetes, the dosage is OD, and of course, the patient, we should always check the creatinine clearance, that is, if eGFR is less than 45, should not be recommended. Diabetes management, the need for a personalized and comprehensive combination of glycemic and extra glycemic benefits. The best from classes that Vildagliptin and Dapagliflozin provides an option for comprehensive management with powerful glycemic control, weight reduction, heart protection, and kidney protection. Vildagliptin 100 milligram in a sustained release form, and the comprehensive combination provides easy of once a day formulation, enhancing patient compliance. Thank you so much.
Thank you for sharing your knowledge and experience, Mr. Aman Gupta, which also covered many aspects of this molecule. We have few questions for that.
Yeah.
Where will you place this fixed dose combination in your clinical practice?
Suppose a patient comes to us with a HbA1c of more than 7.8, suppose 8.2. Whether the patient is treatment naive, normally when a patient comes to us, the patient is already taking metformin. So if the patient is compliant with drug therapy, I would further increase the metformin dose, or I will further add Vildagliptin, add-on therapy I'll use. If the patient is non-compliant, suppose it does not want to take BD dosing of any drug, and if the HbA1c is more than it, I will directly go for combination therapy of this drug. That is OD dose of Vildagliptin plus Dapagliflozin once in the morning.
Okay, Dr. Aman, what will you remember while prescribing this drug? What the first points you will
first, I will just go for patients. First, I'll ask the patient to be compliant with the drug. Second, I'll ask the patient to hold on to the diet for lifestyle modification, exercise. Third, I'll go for creatinine clearance. Of course, I'll check the RFT first and LFT first, because Vildagliptin is very good. Like it undergoes hepatic and renal metabolism. So I'll first get SGOT, SGPT done. I'll get creatinine done, and then I'll put the patient on this combination therapy. If a patient is female, I'll ask the patient whether she has any urgency or any increase in frequency of urination, any itching is there or not. Because since Dapagliflozin causes UTI, I will first take the history about UTI or not. These things we should always keep in mind.
Aman, one short question. As an interventional cardiologist,
okay,
in the heart failure patients, when do you start Dapagliflozin?
Dapagliflozin is being written left, right, and center nowadays. Okay, I mean to say that it is a very good drug. Whether the patient is having heart failure or not, we can start the drug treatment. Initially, the drug was approved only for heart failure with reduced ejection fraction. Now the drug empagliflozin, I mean to say, it has been promoted for heart failure with preserved also, according to Emperor study. So if a patient is affording, obviously I'll put the patient on empagliflozin. But the patient is non-affording, of course, I think already the study is ongoing, and till now their results have been positive. I'll put the patient on dapagliflozin. See, if a patient is having diabetes, hypertension, even if the ejection fraction is normal, we have to calculate the diastolic dysfunction. Normally, patient comes into grade 2 or grade 3 diastolic dysfunction, and we can start the drug. The exertion breathlessness, the complaint of dyspnea, these things will reduce.
And what is your final take-home message for the audience?
We can obviously use the drug, this combination therapy, when the patient comes to us. We can. This is a good drug because it has both the things. Both the drugs act complementary to each other. Mechanism of action is very complementary to each other. If one increases the endogenous glucose production, the other decreases the endogenous glucose production. And a combination therapy, once a single dose therapy, it's a good molecule. It's a good combination, basically.
That brings us end of this meeting, Aman, and which wonderfully enlightened us and me and as well as audience.
Thank you.
And thank you. And we also thank our Imagica Health technological partners for smooth streaming of this video.
Thank you, sir. Thank you so much.
Thank you, Aman.
Thank you.
Thank you, Priya.
Good night, sir.
We will meet in future.
Thank you, sir. Good night, sir.
Good night, sir. So from here now, I'm ending this meeting.
Okay, Priya.
Sure. Thank you.
Thank you. Good night.